disruptive innovation as we speak, in the trenches. And so we're going to obviously hear from them about what they're doing, and then allow, once again, the interaction from all of you to be able to ask very specific questions about the elephants in the room, the herd of elephants in the room that we're all trying to solve here. Before we do that, I want to show you a 2-minute video about how Banyan is addressing some of these challenges that are going on. And we've created and began, it's in its infancy, but it's happening rapidly, to apply our technology, which impacts the composition of your care team. It changes the processes of how you deliver care in a completely revolutionary way. And it impacts your financial bottom line fairly considerably, in a good way. So, 2 minutes. Thank you.
At Banyan, patient care is at the heart of everything we create. Introducing Banyan Care. Banyan Care is designed to make the patient experience more positive, while empowering nurses to truly deliver the best bedside care possible. This system is revolutionary. It enables healthcare professionals to interact with patients and access their information in real time from anywhere. Here's how it works. The heart of Banyan Care exists right where care is delivered, the patient room. The system integrates technology to the TV in a typical patient's room. We add a touchscreen computer, communication camera, fall prevention camera, speaker, and a microphone.
Hi, Mr. Avery. This is Anna, and I'll be helping with your care today.
The touchscreen is placed below the TV, and the TV itself is used as a secondary monitor for sharing content. You have the ability to bring all the content and systems that you already utilize together in this one screen. Electronic medical records, images and diagrams, notes, and other content. Patients and their family members can simply tap the screen to have instant access to their nurse. Providers in the room can use it to perform rounds, mentoring, or simply communicate with a nurse. Nursing staff is notified as to who is calling in, so they can prioritize accordingly and enhance workflow. When a patient or family member taps the screen, it defaults to audio only, so the provider can make sure it's an appropriate time to use the camera. Now, the nurse can pan, tilt, and zoom the camera to check on different visual aspects of the patient room. They can pull up documents or images, make notes and visual references for patient education. From one screen, providers have access to all medical information necessary to make rounds, conduct admissions, discharges, and deliver patient education. Multiple providers can even join in simultaneously and interact with the Banyan application remotely. When it comes to patient education and communication, our tools enable healthcare professionals to interact with patient information in a whole new way. For example, drawing right on the screen to highlight things of importance. Banyan Care transforms patient satisfaction by allowing hyper-communication and collaboration between nurses, hospitalists, pharmacists, doctors, and families right in the patient's room where patient care is delivered. We are Banyan, and we believe in healthcare transformed.
Basically, you're the second audience that has seen that video. We've had it for about 7 days. So, does it help kind of explain what Banyan, what the interactions are with the system? Very good. Well, that is a great segue into the next discussion with our panelists. We are honored to have 2 people who have implemented disruptive innovation and 2 people who are close to implementing disruptive innovation. And I would like to welcome them to join me on the stage. And as I introduce them, when they take their seats, they're going to spend about 5 minutes telling you who they are, where they work, and why they took the innovative journey. So we'll start with Sue Schulke from St. Elizabeth. Yes, you do. Followed by Linda Goodwin from St. Anthony's in Denver. Robin McGinnis, Florida, Heartland Adventist Health System. And Jennifer McLaren from Jennifer Woods from McLaren, Northern Michigan. So I'm going to turn it over to them, and they will get 5 minutes to explain their innovative journey.
Do I have to? No, don't have to turn anything on. My name's Sue Schulke. I'm from St. Elizabeth, and St. Elizabeth is part of CHI nationally, and our journey began at the national level. We started looking at how we could deliver nursing differently. And what are the nurses doing? You know, we talked this morning about top of practice. What are nurses doing that they should be doing, and what are nurses doing that maybe somebody else could be doing? And we started in Reading, Pennsylvania, did some workflow, time studies, spent a lot of time watching to see what nurses do. We took that information then and started a pilot in Kentucky. And in Kentucky, we looked at what would happen if every new graduate had a virtual mentor they could actually take with I think of Sheldon on Big Bang Theory, but they took a virtual nurse into the room with them. And this went over like gangbusters. The nurses loved it. It was awesome for mentoring, but it was just one role of the virtual nurse. So we brought that to Lincoln, to St. Elizabeth, and we did a pilot with 12 beds that were wired virtually, and we looked at what case uses the virtual nurse could do based on the information we gathered from the 2 previous institutions. And we found the virtual nurse could do admissions, discharges, patient education, nurse mentoring, staff education, physician rounding, and one of my favorites, real-time quality metric monitoring. So as we looked at implementing those roles, we at the same time wrote a HRSA grant and were awarded $1.4 million. I know, Carol, you said we didn't need a grant, but we took the 1.4 and we're like okay with it. And so it was fine being poor, but it's better to have money. So at that time we expanded to 20 beds in Lincoln, 24 in Kearney. Judy Moore in the audience here is my counterpart at Kearney. And we have been monitoring data that looked at all of value-based purchasing. We look at COTIs and CLAPSIs and PUPs and VTEs. We look at length of stay, readmissions. We're looking at staff satisfaction, patient satisfaction, physician satisfaction. We looked at NDNQI data, safety survey data, and that wasn't quite enough for us, so we decided to also throw in Dr. Kalish's miscare surveys, because we wanted to know what the nurses still felt we were missing and why they were missing it. We are in our 3rd year of our grant. We're very excited, and I don't want you to think it's been perfect. I don't want you to think we haven't run into some barriers or some naysayers, because we have, but we are persistent. This is a better way of doing things, and we really feel if we're not doing it, somebody else will be doing it, and we need to do it for the patient. That's all I have for now.
Hi, I'm Linda Goodwin. I'm the Chief Nursing Officer for a region of Centura Health. Centura Health is in Denver, and we have 18 hospitals across that system. I had the privilege of hearing about virtual nursing actually from Sue's pilot. Dr. Kathy Sanford is our CNO for CHI, and part of Centura is actually owned by CHI, and part of it's owned by the Seventh-day Adventist group out of Florida, and then we also have independent hospitals. We are a management company overseeing 18 hospitals, and in our region we have hospitals from Denver proper all the way up to Summit, where the ski resort in Frisco is. So a lot of mileage, if you will, across Denver in many of our hospitals. So after hearing Dr. Sanford talk about the success at St. Elizabeth, I asked if I could go up and visit, and when I went there, I fell in love immediately with what I saw, but I started asking questions. I know Sue kept Sue kept saying, really, I didn't thought, anyway, long story short, it just really piqued my attention. So came back and started talking about it at our hospital headquarters, which is in St. Anthony in Lakewood. It's just a little bit about St. Anthony. It's a critical care hospital. Although it's a small hospital in comparison to many across the nation, it's 225 beds, or it was then, it's now close to 250. It has a case mix index of 2.8 to 3.0 for its patients because most of them come from the mountains, who tried to climb mountains, fell, ended up with head injuries, etc., etc. So we have high intensity of care. The other situation that was going on, and why I wanted to pursue this, is that Denver does not have a certificate, or Colorado does not have a certificate of need, and university is right now, as I speak, opening hospitals on every corner to become a very strong competitor with Centura Health. What does that mean? We are all fighting for experienced nurses. Can we hire graduate nurses? Of course. But when you have that type of an intensity of care in your organization, you obviously shouldn't be housed with all graduate nurses, right? So what piqued my interest about the virtual nurse opportunity was the opportunity to develop a new care model. We were getting ready to actually design and implement another floor, 36-bed unit. And one of my colleagues that's here, she can wave, Cammie. Cammie Dyson was picked because of her brilliance and her background in innovation and desire for innovation. She was a former EMT and also worked in computers in the past. She held up her hand and said, yeah, I'd like to be the manager of this new unit. And then I knew I couldn't do it without a partner, and the only way it's successful when you start these innovation projects is to really work with someone outside of nursing, quite frankly, who has the expertise to help you optimize and create the workflows and the change management that you could not do on your own. So Diane Murphy, if you'll raise your hand, she's here today, has been my partner in making this a successful pilot. So we had the opportunity to design the unit, and of course BANYAN was our partner in providing the virtual care component. But what we did, before we decided to just implement virtual nursing, we had to address how we're going to staff it. Because we, at that point, was running a vacancy rate or turnover rate around 20%. All of our hospitals are doing that because we're robbing each other constantly. So we needed to find a different care model. What I decided to do was get a little crazy and insane and go visit DORA, that's our State Board of Nursing, visit the Board of Healing Arts, and also the Oversight Board for Paramedics. And because of the intensity of care, I wanted to bring paramedics in to be partners with RNs in our acute care setting. Got permission, and we began our pilot. So what has come from that is we have a waiting list for paramedics who want to come to our organization and work. The caveat we tied to that is that we own Flight for Life. That is the transportation hub of all, most of Wyoming, parts of Kansas, and all of Denver. And those Flight for Life nurses actually pioneered about 25 years ago an RN paramedic model on the helicopter of how well that worked together and how they still stayed within their boundaries of their care licensure, but still provided extremely great care. So we got permission to pull paramedics into the acute care side. Well, we also specified with them, you do want to come work for us because this is your ticket to become an RN. So we're asking all of them to, within the next 3 years, become a registered nurse. We have scholarship, offered them full scholarships to actually become a paramedic to RN in a 12-month program in Kansas, at Hutchinson Community College, because nowhere in Colorado would they do that. And yeah, now they're interested. Then they would have 5 years. Another retention ploy is they have to have 3 years in ICU, 2 years in ED to become a flight nurse. So by the time they get through school, by the time they are practicing on the inpatient side, you can seal them into an employment stat alignment for about 8 years. Well, that's better than anything we've been able to do. So we offered it. We hired a full-time CNS who helped us pioneer pharmacology for paramedics. We taught classes. We used the simulation lab. They had to practice in a day of the life as paramedics before they could touch patients, etc. Now, let me tell you how we got it through the State Board of Nursing. There is a way. If there's a will, there's a way. If there's a will, there's a way. We didn't try to convince the State Board that nursing was going to oversee the paramedics. They are overseen by physicians, the hospice group. They have a set of protocols they've signed off on, and what they do is deliver all the technical care for our patients. However, the nurse continues to own the patient and design the care model around the patient's need. They work together, hospitalist, nurse, paramedic, and virtual nurse to deliver this care. So there's no argument from any State Board of Nursing, right? So what has come from that is, you can read in the handouts, I've got to turn it over to my partners here to the right, but our clinical and our clinical outcomes are extremely excellent. Our HCAP scores are soaring. We have been able to, as Carol talked about earlier, it's not all about FTEs and hours per patient day. Our hours per patient day on that unit are higher than any other medical surgical unit. However, we're saving, even after the process of starting to pay for our equipment from BANYAN, well, the first few years we'll be saving $250,000 and ultimately a little over $1 million a year on one unit. Because it's one nurse, one paramedic, one virtual nurse, one technician working with a hospitalist for 9 patients, and we have 36 patients.
My name is Robin McGinnis, and I work for Adventist Health System, so I guess we're cousins in some way. So I work in the West Florida division of Adventist Health System. So the system has 46 hospitals across 10 states. Half of them are in the state of Florida. So there's the Central Florida division, West Florida. So I've been newly appointed as the Senior Executive Officer over the West Florida division, so it's over 9 hospitals, but just a second ago came out from being the CNO at a single hospital, so I totally get that world. So we were introduced to Cindy and her team at BANYAN through our divisional CEO, Mike Schultz, is all about innovation. So he was someplace and BANYAN was there, and he came back and said, listen, Robin, I really want you to go talk to them and learn about this care delivery model. So I say that specifically, that there are other folks other than nursing that get innovation and really, want to be the leader in seeing how we can deliver care differently. So we met with the team and then had them present to all of the CNOs in our West Florida division. Because for me, the why was we need to transform care. And I think nursing, we only know one way. And we've been stuck in that same way I've been a nurse for 35 years, and it's, kind of been the primary care nurse model. Maybe I came out of team nursing a little bit long ago, but we've just been in one way, and we've been forcing this fit for one way. This one hospital in our division, Florida Hospital Heartland, is in Sebring. It's in a very rural part of Florida. It's a very, very difficult place to recruit and retain nurses. They are highly reliant on travelers, and at one